Do an evaluation. All right. So it's August, and probably people are out doing fun things. But I want to welcome those of you who are here for our grand rounds this morning. I'm Jürgen Unitzer. I chair the Department of Psychiatry, and I'm going to introduce our grand round speaker for today. I'm going to say a little bit about Dr. Deepa Rao. Deepa is a clinical psychologist. She's an associate professor in the Department of Global Health with a joint appointment in the Department of Psychiatry. She's a licensed clinical psychologist, and her passion is, and she'll talk about what her passion is, listening to, learning from, and partnering with people really around the world to find ways in which we can close the gap that exists in treatment for good for mental health problems. And she does that in a variety of ways. She does research, grant-funded research all over the world, in India, in Peru, in South Africa. I'm probably forgetting a few. Prior in Kenya, and actually even domestically. Her work started in stigma and is now sort of broadened, includes some really interesting work in perinatal mental health, a whole range of really interesting topics. The most important thing I can say about Deepa, she is a wonderful, wonderful colleague. Those of you who haven't met her, you should find a way to meet her. She's smart, she's creative, she's flexible, which is something you have to do if you're going to try to do things all over the world, right? And I'm really happy to have her be our grand round speaker today. And Deepa, why don't you come on up? All right.
Okay, thank you so much for the warm introduction. And these mics are never made for short people, but I'll try my best here. And let me know if you can't hear me. And maybe I'd even encourage people to come up front a little closer if you can't hear me, because there's always, 2 rows of where no one sits. So even though Jürgen gave such a warm introduction, I have a couple of introductory slides to just give you a snapshot of me. I know some of you have heard me speak before, but perhaps many of you have not. And even though I have an appointment in psychiatry, I think, and maybe you see me around kind of in passing, do you really know who I am and what motivates me to work in global health? And perhaps some of you have similar motivations that pick up your interest in global health. So I thought I'd share a little bit. So I'll talk a little bit about my past, present program of research in terms of the work in stigma reduction and what got me launched in this area. And as well, really after coming here and observing the collaborative care model, how I've integrated that work into integrated care work internationally and at scale internationally. And then, of course, it's a necessity for me to talk a little bit about training and capacity building because it really takes up so much of my time and is interspersed with so much of what I do. So I'll talk a little bit about that. So first, I've got a nice old photograph here that I dug up about 1.5 years ago of my maternal grandfather, who was actually an English literature lecturer in college in Bangalore, South India. And even though he was fascinated with all things from the West and fascinated with English literature in particular, I have one of his old kind of falling apart Shakespeare books on my bookshelf at home. He always valued tradition. He would take pride in being able to climb the coconut trees in front of his house to pick the coconuts himself. He kind of didn't want others to do it. He wanted to do it himself. He wanted to preserve tradition and pick coconuts the traditional way. And so he kind of instilled in me this value for always coming back to, doing things yourself sometimes, but also tradition and value for our culture. This is my paternal grandfather, so my father's father. And the interesting thing about him is that although there's a rare photograph of me with him when I was about 7, Uh, he was actually rarely around. He lived in a rural part of Karnataka state in South India, outside of Bangalore. Um, and after my grandmother passed away in childbirth when my father was 2 years old, he developed severe mental illness and was very often not at home. I mean, people couldn't keep track of him. He was away from the home. He remarried, and my step grandmother really ran the household. But knowing his story and the consequences of his story on my family is really what moved me into mental health, with an eye always towards culture and the differences between the impacts of living with someone with mental illness, both in India and here, and just kind of comparing the two. It moved me back in 2003 to actually go and pick up and live in Bangalore. I was talking before about being born and raised in Chicago. I think at this point I've been here about 10 years, so I've lost my Chicago cop accent. So now it kind of sounds Seattle, maybe. So I trained in Chicago, and I got the opportunity in 2003 to go and live there and conduct my PhD dissertation work in India. So I went daily and conducted a research project at the National Institute of Mental Health and Neurosciences, and really got to learn so much about systems, mental health systems, shortages in healthcare worker resources, and I mean, for example, the whole system at NIMHANS was built around the fact that, there are no mental health nurses to help care for inpatients, well, very few. And families had to go out and get medications for inpatients who were staying at the hospital, and often stay beside the patients that are staying in the inpatient units of the hospital. And so you can see this photograph of a security guard at NIMHANS in the outpatient facility. Behind him, though this is the early morning, there are usually people knocking on the door. When am I next? When am I going to be called upon next? Waiting in line hours and hours to be seen by a psychiatry resident that sits before him. So, there may be 4 residents that screen the outpatients that come in for the first time. There may be behind him waiting 500 families to be seen in a day. They might have a couple of minutes with each patient. But that was really how it gives you a sense of how under-resourced things were and still are at NIMHANS, which is a specialty tertiary care facility in Bangalore. So I was there and I conducted my research in the local language, and I got to hear deeply affecting stories from the people who I interviewed. And what struck me most in the work that I did was the story coming from the women that I worked with, and what they endured and their resilience. But it really moved me and propelled me forward into doing the work that I do. So I'll talk a little bit about that now. I came back to the States. I settled in Chicago. I did my postdoctoral work in Chicago, and partly because of my experiences at NIMHANS, I focused my work on stigma reduction at that point. And so, I had this choice point in Chicago. The work and the research was very domestically focused, and so I chose to kind of start my line of work domestically. And Chicago is a very diverse city, 50% African American, and I was struck by the numbers and the statistics that I was seeing around HIV stigma. So back then, I wrote for and basically started a line of work responding to the patients that I was seeing in the clinical program to develop a stigma reduction program for African American women living with HIV. Many of the patients that I was working with back then were really demanding something. We want something for us. We want something to help us deal with the stigma we're facing within our families, communities. And so I started a line of work that really began very qualitatively, where we developed an intervention that we called the Unity Health Study. So this started, I would say, a 10-year line of work where just I guess, end of June, we completed the R01 study looking at the effectiveness of this intervention. So I'm going to talk a little bit about the findings, which are quite exciting. And I can take questions if you have any on the development of the intervention. You know, that was a good 2-3 years, and then the pilot testing another couple of years, and then we did a full-scale intervention trial that just ended, and we're getting the papers from that out now. So these are some of the statistics I was struck by. If you consider that 66% of HIV infections in women occur in African American women. Also, the death rate of African American women with HIV is 15 times higher than HIV infected white women. It's quite striking and staggering. What I was reading at the time was that studies showed us that for African Americans living with HIV, oftentimes in order to avoid stigma, they would not adhere to their medication regimens. So, you know, I know that stigma isn't the only reason why we're seeing some of those numbers and rates, but I thought, well, why don't we see if we reduce stigma, if it makes an impact on medication adherence, if people improve their adherence, engage in care better, and then ultimately we see better health outcomes as a result. So after starting this work in Chicago, I moved here, but then continued the work in Chicago and added the University of Alabama at Birmingham HIV clinic as a site for recruiting patients for this particular intervention. We conducted a randomized control trial where we compared the Unity Workshop, which is a group formatted workshop that's led by a peer, another person living with HIV, to work with the group members on stigma reduction techniques and coping skills. And the comparison group was a group of women that led by a social worker, where they went through breast health kind of prevention messaging. So we conducted a mixed effects regression of the outcomes. So we measured basically from African American women over the age of 18, the stigma scale for chronic illness, which is a scale that we validated for African American women living with HIV and men. It's a 14-item scale, and we measured stigma at baseline, post-intervention, 6, 8, 10, and 14 months. So it was a nice, well-planned, thought-out longitudinal study, with one exception. The control group, the breast health workshop, had a lot of similarities to the Unity workshop in that there was a lot of social support in both arms of the study. And so we didn't see an effect across arms. There was some stigma reduction, but as you can see, it kind of creeps back up over time. But here is where our key findings, at least in our interpretation, lie. Basically, social support seems to be key to stigma reduction. So we saw stigma reduction in both groups, and the key mechanism by which stigma was reduced is social support. So with every one standard deviation decrease in stigma, we saw an increase in social support. And, you know, conversely, the same with an increase in stigma, we saw a decrease in social support. So that was quite interesting for us. It really coincided quite a bit with the qualitative process data that we were obtaining from the patients. They really valued their connection with the other women, so much so that when the trial ended, they were trading phone numbers and asking, well, when's the next group? Then we tried to integrate the Unity workshop materials into their ongoing social support groups. The other really interesting findings that are soon to be submitted for publication is an analysis. It comes from an analysis that actually my PhD student Christopher Kemp is working on currently. It's all written up, probably going to be submitted next week. But what he did was we measured viral load, you know, copies of HIV in the bloodstream at each time point after we collected the stigma data. And so he looked at basically whether or not when stigma is reduced, viral load also decreases, kind of connecting the psychosocial with the biological outcome variable. And he was finding that, lo and behold, yes, there is this strong connection, linkage, association over time. When you decrease stigma, viral load also decreases. When you increase stigma, viral load increases. So that was quite interesting and encouraging. And next steps for this study are that we're actually a team, oops, let me go backwards. A team in the Deep South is actually taking Unity intervention materials, adapting them for men, and then rolling them out in community-based organization centers. And what we're going to be doing there is actually more of a waitlist controlled design. So we'll actually be able to see if over and above nothing or treatment as usual, we see an impact on stigma. So that'll be interesting to see the results from that study. And it's nice to see that, you know, in the Deep South, where it's a, you know, very heavy prevalence of HIV in population there, if we can make some inroads and impact. And it's nice to be picked up by community-based organizations in a slightly different setting from where we conducted this initial work.
How much of this is related to medication adherence?
So we are looking at some of that. We're not finding so much of a connection. We're looking at the mediation models now with adherence and engagement and care. And part of that could be that our engagement and care variables are kind of weak. It was really tough to kind of combine, you know, visit data from 3 different clinical settings. And we don't have a uniform way of collecting visit data. So we're not finding anything now, but we're trying to strengthen our way of looking at the data to kind of be able to isolate that. But that was our hypothesis, that that would be the mechanism that stigma impacted viral load. So if it's okay, would it be okay if I just move through real quick? Because I actually have a lot of slides, which is unusual for me. I'll take questions at the end if that's okay. So while I was doing this work domestically, I always have an eye towards going back to India and doing work in India. And the nice thing was, over the years that I've been here, you know, there have been studies that have pulled me in to do work in India. I think maybe perhaps many of you have heard of Lydia Trastia's work with bringing team care to India. I'm involved with some of that work, but what I'm going to talk about today and here is actually some work I'm doing with Amrita Bhatt, and we are hoping to integrate mental health care into antenatal care settings to ultimately improve outcomes around PTSD, so, and depression in the country. But my focus, and partly this is motivated by the interviews that I conducted in 2003 and doing when I lived in India, was I was very much impacted and weighed down by the experiences of women and the violence that they experienced at home. And so if you just kind of take a look at the WHO numbers on violence against women, you'll see, you know, this is obviously a problem that exists everywhere throughout the globe. You have some higher prevalence rates of violence against women in South Asia, around 37%. These are actually underestimates from some of the papers that I've seen that show rates around 40% in India, 50% in Bangladesh. But at least you kind of see within the perspective, global perspective, where South Asia falls in terms of violence against women. There have been some that have explained these numbers in terms of, you know, religion, customs, age-old prejudices that have put women in an exploitable position. Think and consider the backdrop in India where women are not encouraged to go to school. Maybe 75% of men are literate, but only 54% of women are. And I think maybe many of you have heard there are, and this is, you know, just a backdrop, a setting type of issue, but there's a preference for the male child that really center around and have origins in religious customs, but that leads to sex selective practices. You know, interestingly, ultrasounds to determine the sex of the fetus are actually banned in India now because oftentimes women, if they knew they had a girl child, would abort. But this brings me down to one motivating factor. I don't know if many of you admire the work of Chimamanda Adichie, you know, the Nigerian novelist, but one of the things she said in her We Should All Be Feminists TED Talk and also her book is this, because, you know, if you think, well, some of these things are happening because of culture, what can we do? She says, culture does not make people. People make culture. If it is true that the full humanity of women is not our culture, then we can and must make it our culture. So this idea that we can change culture, we can do something about this, it really resonates with me. So I'll talk a little bit about, the quantitative work, more from an epi perspective that I've done in South India. We were really interested, and we got some funding from Global Watch, which is a local center for the health of women, children, and adolescents, to look at this particular research question. Among pregnant women, how does the experience of domestic violence and its mental health consequences impact birth outcomes? So we worked mainly in Tamil Nadu at a semi-rural private hospital, and as well an urban public hospital in Chennai. We recruited women in their second trimester of pregnancy, and then followed them until the birth of the child, and then collected data from the medical record on birth outcomes. We looked at sociodemographics, psychosocial variables. Although these are Western measures that we use, like a PHQ-9, a PTSD checklist, they were validated and used in Tamil, the language of that state. And then these are the birth outcomes that we collected, just to give you a quick snapshot. So it says demographics are, we mainly surveyed younger women. That's the way the sample turned out to be. 100% of them were married. And as you can see, there's kind of an even split between schooling in terms of secondary schooling versus college and above. Here's what we found. I'm just giving you a quick snapshot because I actually going to talk a little bit about my work in South Africa. But really what we found was that depressive symptoms and psychological abuse were risk factors for prematurity in the child. Physical abuse, as you can see, kind of moved more towards the trend area. It wasn't statistically significant, but it was, we did see the direction of that effect going in the right way. And maternal education is actually a protective factor for prematurity. Interesting. And what one would think, it's quite intuitive. What was also interesting was that when we looked at PTSD symptoms and compared them to, rates that we see in the US, really there was a major difference between when you scored the PTSD checklist using a diagnostic scoring versus having a 30 total score of 30 cutoff. There was a vast difference in who met an alarming criteria of being, significant PTSD symptoms versus not. And so that was interesting for us, especially given the rates seemed higher when you use the 30 as a cutoff. There's also, we looked at depressive symptoms, and if you use a PHQ-9 symptom cutoff of scores less or above 5, 21% seem to have some significant symptoms of depression. Here's what I think is important to consider is that 21% of the women were lost to follow-up, meaning that 21% of the women didn't deliver in the hospital where we were tracking them. It's a custom in India that women, especially for the birth of the first child, travel to their natal homes. So they gave birth in a different hospital. It just gave us a clue in that if we wanted to track them, we had to kind of follow them to different hospitals and be a little more mobile than we were with this pilot study. But the other interesting thing is that PTSD wasn't associated with birth outcomes, and we think it has something to do with the oddities with the scoring and the fact that it's a Western-based instrument. So something's going on there with the picture of PTSD where many of the women endorsed the items, but didn't quite meet criteria for PTSD. So, this could be that the women, if they're experiencing domestic violence, which, they were, according to our numbers, particularly psychological abuse, it's not coming out as PTSD. Maybe there's some resilience in the population, but the other issue was that the measure may not be the most appropriate for this population. So what's the significance here? It has us thinking a little bit that with such high rates of prematurity in India, perhaps if we had developed psychosocial interventions and used them in the antenatal period, perhaps we can see an impact on prematurity. It's an idea thought. It's fueling our next steps to try to do integrated care work in antenatal care settings in India. I, along with my partners in South India, as well as Amrita Bhatt, are looking at using interpersonal therapy in antenatal care settings. And we're going to look at depression reduction, but also impact on birth outcomes and maternal outcomes. So it's kind of the direction the work is going, but it's kind of slow going because, we need to get some pilot data on IPT. And Vikram Patel has done some work in IPT in India, but he was finding a real poor engagement with the patients in the study and following through with the intervention. And so we're trying to improve on that, perhaps by using Nancy Grote's model of adding motivational interviewing to the start of it to engage people in IPT and then ultimately delivering the intervention. So that's kind of where that work is headed. Why integrated care? Why this, are we looking to antenatal care to bring mental health in India? As I mentioned before, the integrated care model lends itself well to a setting where there are mental health worker shortages. We more effectively use the time of psychologists and psychiatrists when they're consulting. It's advantageous for us to train nurses and other healthcare personnel to be able to do some of the identification and psychosocial counseling. The other thing that this model does is, and why it's a benefit for use in India and other places, is that it lends itself well to adding community healthcare workers to the model to help identify cases of mental illness and link patients to either primary care or specialty care facilities. And the extraordinary thing about adding community healthcare workers to the collaborative care model is that this is kind of a system that we don't even have here in the United States. We don't have a model here where there are these easy linkages with community healthcare workers to primary care, to specialty care. And we're able to do this work in these settings where there are these strong connections in the public healthcare systems. So there's an advantage for us in that way. And in another way, we're just sharing of tasks and kind of evening out and truly working collaboratively as teams. And so that model is really being rolled out in many places with a lot of support from funding agencies like CDC, with PEPFAR money in HIV, but also we're seeing interest in using these models from USAID and other funding sources. So that brings me to the work we're doing in South Africa, which is a little more advanced in terms of the translational research kind of trajectory than the work we're doing in India. We're kind of at the starting stages there of that work. In South Africa, and by the way, like on all these photos, you see all these photos or all these slides, you see photos of people. These are all of my collaborators, mentors, students, people who, to tell you honestly, I would never be able to do this work without all of them. I mean, really, it takes everyone. So this may be my work, but it's not really my work, if you get me. So in South Africa, this issue of collaborators actually plays a major role because I and my team here in UW are coming in at a time where researchers in South Africa have actually come a long way on this continuum of translational research. Crick Lund, Inga Peterson have done a lot of work with validating the collaborative care model in South Africa. They really hit the discovery and developmental ends of the translational research spectrum quite a bit with work that was supported by PRIME and the United Kingdom and their kind of USAID counterpart in the UK, where they looked at and are continuing to look at the data from using a collaborative care model in Northwest Province in South Africa and measuring hypertension outcomes. And they have another study that's NIH funded where they're looking at HIV outcomes. So they're rolling out collaborative care in public primary care facilities and looking at outcomes for cardiovascular disease as well as HIV. So that's the other advantage to working in primary care, is that you can roll out integrated care models and really try to look at impacts in various across conditions. So this is where UW comes in. So UW is coming in where there's been this preliminary work with PRIME and COBALT, which is the HIV study. They've got some data that they're looking at around effectiveness, and they're finding some positive numbers in terms of 50% reduction in depressive symptoms measured with the PHQ-9. What we're doing is trying to scale this and make it sustainable within the public primary care system. So what that takes is kind of a movement from your classic research study designs where you're looking at effectiveness, maybe cluster randomized trials, and moving towards strengthening referral systems in districts and making sure that when people aren't getting better at the primary care facilities, there are places to refer, and strengthening those linkages with formulating district mental health care plans. But then also at the provincial level, negotiating ways that we can work with already funded staff in the primary care facilities and train them to be the psychosocial counselor or the care manager in the collaborative care model, to use a different term. The PRIME studies and the COBALT studies paid the lay counselors to become the care managers and to become what they call psychosocial counselors. But with this new model, MINT and CDC funding, mental health integration, we are working with provinces to make sure that in their budgets, they're earmarking time and space to have psychosocial counselor available in all the clinics to take on the training to be able to do really CBT. We're training them in CBT under supervision from other mental health care personnel in districts. And so that's the work of MINT, and we're moving on and continuing to negotiate how far we can scale in district by district in South Africa. So let me just check the time. Okay, so as you can imagine, this work of MINT involves a lot of training and supervision. It's not something where we can just roll it out and then leave. It's quite complex. So there are a lot of training programs that we're rolling out with CDC funding. We're training primary care physicians in provision of antidepressant medications. We're training quality improvement nurses, or nurses that have more of a management role in these primary care facilities, in two different modules. One, APC, which is adult primary care, identifying cases of depression, alcohol use disorder, anxiety disorders. We're also training them in quality improvement techniques so that they can serve as supervisors to the nurses who are doing the day-to-day face-to-face work with patients. So we're training them in quality improvement techniques. They and we, our staff, are training primary care nurses in identifying mental health issues and referral pathways. And then here's where the real psychotherapy training happens, is at the level of master's and bachelor's level psychologists. So they are trained to be supervisors of provision of cognitive behavioral therapies, and then they supervise and we train right now in the model ART counselors. So as you can imagine, South Africa is a country that has a very high prevalence of HIV, and the government has placed high school level educated ART counselors in all of the primary care public facilities in South Africa. So this is a ready cadre of worker that can take on CBT counseling. And so we're training them to be able to do this under the supervision of bachelor's level psychologists who can travel from facility to facility and provide supervision for CBT. And then the master's level psychologist kind of really oversees a lot of the work in a certain number of facilities, about 15 facilities. So, it's kind of a apprenticeship model in a sense, in that there's a hierarchy of training and a hierarchy of supervision. But this is the way that we're able to reach so many in the districts where we work. Okay, so these arrows just demonstrate how the supervision flows, that the quality improvement nurses supervise the facility nurses, and then master's and bachelor's level psychologists supervise the HIV counselors. And this is just kind of a pictorial image of the cascade model of training, and how we're able to reach so many staff in so many facilities. We're working about, per district, about 30 facilities per district. And so these are the districts where we're working. The formative and pilot work, and we're continuing to kind of monitor and track data. Where the work started was in Dr. Kenneth Kwanda district in Northwest Province. Prime and Cobalt continue to function in Bojanala district, so they kind of scaled up to training in the neighboring district. Similarly in Northwest Province. With CDC funding, we've moved to scaling this model in Amajuba district, and this is actually a recent change as we've moved away from Sabande district, and we're now in Ahlanzani, which is just north of it. So we're thinking about 30 facilities per district right now. And on top of this kind of CDC funding, just last year, we're funded to do research on the scale up. So implementation science research, where we're looking at implementation science outcomes like re-aim, reach, effectiveness, adoption, implementation, and maintenance, and as well looking at multi-level factors that influence outcomes from the CFIR model. What does this look like? Really, we're operating on 2 different levels and 2 different aims, where we're looking at costing data, patient cohort data, qualitative process data on at the patient level, as well as the level at the facility, and then provincial and district Ministry of Health staff. We're looking at individual organizational and structural factors and how they might play a role in these implementation science outcomes. So to give you a quick example of an implementation science outcome we're looking at, one of my doctoral students, Chris Kemp, he's actually going to be leaving in 2 weeks to spend 6 weeks in South Africa, where he's going to be interviewing nurses. You can see that the PRIME data is telling us that nurses that we train can successfully identify cases of significant depression with the PHQ-9. So before training and after training, they're able to identify, many more cases than they had before, and as well with alcohol use disorders, using, I think, a version of the audit. But what we're finding, if you look closely at the data, is this varies. The success rate of identification varies based on what facility you're at. So each line here represents the number of referrals that the nurses are providing to the lay counselors in each facility. And there's one really well-performing facility here, Grace Makomo, and the other ones are kind of moving along. I mean, there's, they wax and wane with the number of referrals based on what's going on at the facility at the time. But what we're really looking at is we're putting a lens on, well, what factors promote, more referrals by the nurses and what don't. So my doctoral student is interviewing the nurses. I said, well, do you have the support of your facility manager in the work that you do? Are you finding that, there are any structural barriers, perhaps people not open to the work that you're doing in the facility? And we're kind of going to look at that data and compare it to the referral data that we're getting, and kind of try to, with a kind of iterative model, improve the rates of referral in the facilities. Okay, so that's a snapshot of the research work I'm doing, but I do want to mention that I spend about 40% of my time in training activities. And even, this last research study that I mentioned has a lot of training that goes along with it. And part of the reason why I focus so much on training is because I really feel and believe that this is our role in global mental health. Our role in global mental health is not to go and travel and, take a safari and have a nice time, and nor is it our role to go study a population, write a paper, and gain from it, have another paper on my CV and leave. Instead, it's my role, as I see it, to train local people so that they can deliver a more appropriate intervention than I ever could, because I'm a foreigner. I'm not from your country. I don't know all the nuances that are going on. And that's the role I take as well with the work in South Africa. It's so advanced that what is my role here? Well, why don't we look at this model? Why don't we pull it apart and see, if there's anything from our experience we can add to this, or our knowledge of looking at implementation science data, how can we improve this model and train folks rather than trying to do it myself. Some of that training, I think a happy byproduct of this work is that the bi-directional learning that happens, that I learn so much from them, probably more than they learn from me. And the same is true domestically as well. So I'll talk a little bit about my domestic training, but also international training. I teach 2 courses. One of them I'm kind of transitioning to someone else, but I teach global mental health, which started several years ago with 15 students. You can see one of your old residents here took my course the first time we ran it, Rebecca Hendrickson. It was when she gave birth to her first child, who was actually in the photo. But so this was the first time we taught the class with some funding from the South Asia Center. And then since then, we've grown to have 181 students, undergraduate and graduate. And we have a distance learning section too. So we can reach people that may be at the WWAMI sites, and not here on campus. I started a course with Charlie Mock called Global Violence and Health that also grew over time to have 192 students this year. I also teach MPH students in a workshop where we talk about, what's the right way to do global health research. Well, we don't talk about it, we discuss it. That there is a lot of bi-directional learning there. And I have a lot of international students that I train that are located internationally, but also located here. So in our MPH program in global health, we have about a third of our students come from other countries and spend a year or two here and take our courses, and we interact with them, and they do research projects back at home. So this is some snapshots of some of my trainees. Over the 10 years that I've been here, I trained students from all professions and have spent time on committees about 48 students, master's, PhD level and postdoctoral trainees. And I'm starting to have K awardees that are writing and submitting and obtaining K grants to do global mental health work. Jürgen mentioned our work in Kenya. In Kenya, and Ann Vanderstoep was instrumentally involved in some of this work and continues to be involved with this work, actually. We trained 6 University of Nairobi faculty and 45 graduate students, excuse me, and we conducted annual workshops. And the nice thing about that work is that since we work there, we've seen the trainees submit and have in print or in press 15 primary authored articles. So this has been fabulous. This is an institution where they would complain that they would write a thesis for their doctoral dissertations and shelve them, and they would never see the light of day. So now we were starting to get people interested in publishing and peer-reviewed journals, and that's really been very much Ann Vanderstoep's kind of child, and she's nurtured the work over the years and spent a lot of personal, close time with the trainees from Kenya. So the U19 that I mentioned, we call it SHMINT, by the way, Southern African Consortium for Mental Health Integration. It's a horrible acronym that we came up with in a long car ride going out to a site. But we're trained, part of it is the research, implementation science research that we're doing, but we're also training 8 trainees at various levels of the healthcare system in 3 countries as part of this work. So in South Africa, as well in neighboring Mozambique and Tanzania. And we're training district healthcare workers, we're training Ministry of Health staff, and we're training academics, 8 in each country, as I said, but primarily coming from rural parts of these countries in implementation science research, using our work as a kind of incubator for what they can begin in their home countries and districts. So we're putting together some short coursework. We're setting them up with mentors, both in South Africa and locally in Tanzania and Mozambique, and as well in the United States. We're setting up peer mentorship networks. And ultimately, we're going to roll out early next year an online implementation science for mental health course that can be self-paced and taken on their own time. These are some of the methods that we're training in. I won't go over them, but I can certainly talk about some of them. And in addition, we're training in basic, epidemiological methods, and as well writing, grant writing, and manuscript writing as well. I have a video that I'm not going to play because I don't have a lot of time. But this is kind of an inspirational video of a woman who was a participant in the PRIME studies and talks a little bit about the changes that have come into her life since being somebody who's taken part in the program. And of course, as I mentioned to someone before, I couldn't do any of this work without the generous support of all of these institutions that I've named here on the last slide. But it's been a pleasure being at UW and being able to kind of see and partner and see this work move forward over the last 10 years. So thank you. I know you had a question in the back, and do you remember it? Okay. Yes.
Thank you again for your talk. I'm from Orissa, which is a few states over Tanzania from Bangalore. And maybe it's just from Orissa, but there's a huge stigma against mental health in general. So much so that we just tell our family that I have a bachelor. So I was looking for integrated setting, how using care managers and community health workers may actually make people more willing to engage in talking about this. Had to see a psychiatrist directly.
I'm not sure if I have any thoughts on that because you kind of explained it right there and then, right? So, I can restate what you said, but basically the integrated care model lends itself well to, I guess, destigmatizing seeking treatment for mental health issues, right? Because if you are seeking treatment from a primary care physician, you don't have to tell anybody what it's for, or it could be in the context of a couple of other problems that you're also seeking help for. It takes away the stigma that's associated with seeking treatment at a specialty care facility or specialty care provider. So yeah, I mean, that's the biggest advantage. The one challenge that comes up in doing this work, though, is some of the things that we're looking at with the implementation science outcomes is that oftentimes facility managers, staff, nurses don't want to take on the task of providing mental health services. And what do you do there? So what they're doing in South Africa is that they're working in groups with facility staff to promote change management, to destigmatize mental health care, to show that if you intervene on mental health care, look at the impacts on other health conditions. So, it's slow, but it's necessary work. And
so if you're having a hard time telling your family that you're a psychiatrist, think about what the clinic feels like when they have to start telling their clients they're starting to see mental illness.
Yeah,
it goes all around. If it's that pervasive, it's really a challenge.
In the work in independent that Lydia Trostiak PIs here, we had a diabetes care physician that said, there's no way I'm going to treat somebody with mental illness here. And, it was quite a challenge, but I mean, I think we kind of, at least in our initial work, we were able to, implement the program. So still have yet to turn the data, but other questions?
Yeah. You mentioned that you weren't able to correlate the falling viral level with compliance. What measures of compliance did you use?
So we were using there are some adherence items that are commonly used in the adult AIDS clinical trials studies. So we use those items: monthly recall, percentage of times you've taken your medication in the past month.
So
Yeah, yeah. Oh, yeah. I mean, the other measure we have is viral load, CD4 count, which, yeah.
So
like,
then,
yeah.
But so I was thinking, could you get pharmacy data on who's actually filling prescriptions and stuff like that, or are they just mailed to them?
So the challenge with pharmacy data is that there are different ways that different people obtain their medications, right? It's not all from the same place. It's the same challenge that we have with engagement to care data, right? That each facility has different ways of collecting such data, and to unify it is really tough. Some people are using their private healthcare insurance. Some people are using, state healthcare insurance. Some are, on maybe Ryan White funds and getting medication that way. So it's quite challenging to it's not all coming from one source. We didn't measure that. There are some folks that have done pill counts and things like that. We didn't do that in our one study. It was mainly the self-report adherence measures, looking at the medical record for engagement and care data, and then the viral load and CD4 count data from blood tests, also in the medical record. So, yeah. I mean, really what our holy grail was looking at the blood data, the viral loads. And we were really looking to that to kind of show us
the one choke point in that system is 85% of prescriptions are filled through like 3 pharmacy benefit managers, and they've got all the data. And sometimes they'll give you like a 90% discount for academic, which amounts to $100,000 to get the data. But they have that. That's why they send us letters every once in a while and say, your patient might not be compliant. So it's already out there. Somebody's already looking at that, what they're filling. And because if you just ask them, are you taking the meds? They've been lying before, and now maybe they're really taking them. So that conversion from pleasing their doctor to actually doing it is secret.
Mm-hmm. Yeah, so there is like a black box, like you're saying, in there. But the primary outcome was stigma reduction. So, and then secondary outcome, we looked at a few other psychosocial issues like depression, and then, but really we are very interested in biological outcomes. To tell you honestly, these days, NIH, the HIV group, is not even funding studies with stigma as an outcome or a psychosocial outcome. They want to see outcomes on the viral load spectrum. So that's kind of what we were kind of trying to focus on, more than adherence and behavioral data. So, yeah.
Last question. Is it possible that the association ran the other way and that it wasn't the other way?
Yeah, that's a good question. It is possible because although it's longitudinal data, I have to ask Chris Kemp that, if he accounted for the direction in his analysis. But yeah.
Well, because if your viral load is high, you're probably not taking very good care of yourself. If you're sicker,
and you visibly look like you are a person living with HIV. Yeah. And it's more recognizable.
It makes complete sense that you'd be dealing with more stigma, right?
Yeah. Best thing I could do is I could say, email me. I will ask if we can look at that in our analysis. And actually, something I think about as we submit this paper, that may be a query of a reviewer. So thank you for bringing that up. Yes.
I was interested in your slide about scaling up mental health services, training of high school educated folks to CBT. What I wondered is, what's the acceptability or the uptake of the CBT as trained to those folks in that Indian population? Is it well received? Is it useful? Is it culturally appropriate?
So the CBT is, and training of lay healthcare workers as it is now is in South Africa. And so it's okay. Is it culturally appropriate? And they have, so this is why I have to highlight the fact that I'm coming in later into this system later. The South Africans themselves have developed the materials, adapted them for the context, readapt them for different districts that have different cultures and languages, and are rolling that out. And they have had ART counselors, HIV counselors that have really enjoyed being peer counselors. The counselors have enjoyed having the tools to be able to intervene on problems that they've seen that they didn't know how to intervene with before. I think that the main challenge and issue has always been workload and extra pay for taking on extra work. And that is kind of an ongoing issue that's being handled at the National Department of Health level. I mean, to tell you honestly, there are strikes. There are strikes in some of these provinces we're working. There are strikes at the national level in front of the National Department of Health building, basically because the community healthcare workers and adherence counselors, lay healthcare workers they want more pay for what they're doing. They're being asked to take on more and more and more. In mental health, we're not the only people that are asking them to take on our work. I mean, maternal child health, they're being asked to take on things. In HIV, they're being asked to take on home testing. So, community healthcare workers and lay healthcare workers are being asked to do more and more, and it is an issue. I don't think it's the mental health per se, though I do think that at the healthcare level, the physicians, the nurses, they have some hesitancy taking on mental health as an issue. But
I have to wrap this up. I
Sure.
want to thank you for a great presentation. I think this is a beautiful example of a person who takes clinical skills and research skills and a real passion for training, and has a lot of guts and goes out and does some really amazing things. And I do think, I hope that before long you're going to bring back the concept of, to do CBT, you don't have to be a PhD psychologist, because most people in this city don't ever get CBT. And so we probably have to think about, if you could do it in South Africa, why couldn't we do evidence-based psychosocial interventions much more broadly, in a place like this? So I think there is going to be hopefully some bi-directional learning. But fabulous presentation. Thank you very, very much.
thank you. Thank you.